And I hate to be completely shallow about this, but why not? I am. As a fashionista, if I was going to get knee replacement, the scar is so
Oh my
huge.
God, Diane.
Hi, everybody. This is Diane Gilman, formerly known as the Queen of Jeans, but now the proud host of my podcast based on the title of my second book, Too Young to Be Old. And whoa, do we have a guest today? So, do you have aches and pains? How's your back? How's your knee? How's your hips? How's your spine? How's your neck? If you go to any of those, you are going to want to listen to Dr. Mary O'Connor, better known as Dr. Mary, who wrote the book, Taking Care of You, Empowered Women Guide to Better Health. So I have a million questions to ask you, Dr. Mary, because I live with pain. I was born with one hip 3 inches higher than the other, and that led to all kinds of problems. As a runner, I say you're damned if you do and you're damned if you don't. I ran for my health, but I got severe arthritis in my knee, same side as my higher hip, and it is killing me. And totally, you have to teach yourself to live with degrees of pain that are ridiculous. And I asked Dr. Mary this question because she is a superstar who began her career in orthopedics, first at the Mayo Clinic and then at Yale School of Medicine, and is, in fact, has a million awards for the help she has given us. So I want to know something. As a former U.S. Olympic athlete in rowing, did you come into your current years with any kind of aches and pains in your elbows, in your shoulders? Did you pay the price at all for being a really serious put the pedal to the metal athlete?
Yes, Diane. I wish I could say I wish I could say I'm not paying the price now, but I am. And my athletic career combined with my profession as an orthopedic surgeon added to the price that I pay. People don't think of surgery, particularly orthopedic surgery, as being as physically demanding as it is, but it
Oh,
actually is very physically demanding.
oh yeah, I can imagine. But you do something that I think is so fascinating. Before we get into the aches and the pains and the knees and the shoulders, virtual medical care. You are at the forefront of that. Explain to everybody, what is virtual medical care in an age, I will say, where I feel I almost never have personalized care. I feel everything is so rushed and so look at the rule book and yeah.
So, Diana, in a nutshell, virtual medical care is basically what we're doing now on a virtual platform where you are connected with your doctor or physical therapist or health coach or registered dietitian if you need advanced nutritional support through a Zoom-like platform. And that's how you interact with your clinicians. And it is surprisingly not surprising to me, but surprising to some people how effective it is. And there's actually very little lost in the virtual space. There are some limitations because, the clinician can't lay their hands on the patient.
Right.
But a lot of that is actually not needed in terms of being able to make a diagnosis or actually prescribe very effective physical therapy. So when you look at the benefits of telemedicine, which is incredible convenience for patients and flexibility, right?
Yeah.
And access,
Yeah.
then we think of how the healthcare system really should be. Now, I'm going to go pretty high at the moment, but just stay with me for a moment, right? If I was the queen of the universe and I could redesign healthcare, the way that I think it should be given, right? For me as
Yeah.
a patient or my loved ones, it would be virtual first, unless it's something that's truly an emergency, right? If you're in a car accident and you fractured a bone or you think you're having a heart attack or a stroke, okay, you need a good medical center because you need urgent care in that moment.
No, I get it.
But for
Yeah.
everything else, it should be virtual first.
Yeah, somebody could read my x-ray over a screen, explain it to me, and give me options. Now, I want to say that I misunderstood something you said in the beginning, but it's interesting because it's all under the umbrella of the fact that as we age, one of the real points that cause old age to be a drag are the aches and pains you get of the bone on bone thing.
Right.
For me, it's in my right knee. So I just saw a special on this, I think on CNN, but they had Jeremy Renner, who was run over by his own snowplow.
Yes.
And now all of his lower bones below the knee in both legs are really supported by metal aluminum rods. And the guy was out sprinting.
Mm-hmm.
And I'm thinking to myself, you're the kind of person, Jeremy, that can go through a surgery and you're so good at your own rehabilitation. You really work with the physical therapist. For me, I have a very hard time. I have physical therapy once a week, and they've decided it's now my hip with the congenital condition of being 3 inches higher that's making my knee as bad as it is. Medicare will only allow me to get 2 gel shots a year. I can't wait. Next Tuesday, 2/15, I'm in, baby. But, you know, this is something I never foresaw in my old age. And I also feel like I'm sort of pushed around by the medical community a lot and don't get a lot of what I want, which is one-on-one explanations, determinations of how I can take care of a lot of it for myself and work with physical therapists. Are women less likely to get good health care in this area than men, or are they less likely to take care of themselves
Both.
in their
Both,
okay.
Diane. I mean, it's a complex situation. Women in general receive less quality health care than men.
Why?
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 Well, because the system is still biased towards men.
Oof.
I'm just, I'm not saying that to be offensive to anyone, but we are, as a society, conditioned to not believe women. So when a woman comes in,
Wow.
well, I'm staying, I'll stay in my medical lane here, right?
No, I think that's so amazing.
But here's the example. A woman goes into the emergency department or to the doctor and says, my knee pain is 9 out of 10, with 10
Yeah.
being really severe pain.
Yeah.
And a man comes in and says, my knee pain is 9 out of 10. We are conditioned by society to believe that the man is having horrible pain and the woman is having pain, but, somewhere we kind of think she's exaggerating her pain.
Yeah.
Okay.
Yeah.
So all of us carry this bias because that is how we've been raised in this society. And that helps contribute to the fact that women's symptoms are often not appreciated for the reality that they are.
That is incredible. Now, I made sure I had a woman as a doctor, but she walks into the room and I love her to death. I really like her, but her thing is, okay, Diane, I've got exactly 12 minutes. That's it. So I don't really see her beyond 6 months at a time. And I get the gel shot, and I get cortisone shot first, and 6 weeks later, I get a gel shot. And by the time I'm getting the gel shot, I'm ready to shoot myself. The pain is so ridiculous. And then I'm just going to be honest, every single time she says to me, so, you know, you're a candidate for surgery and knee replacement. And I say every single time, I would not be a good candidate because I hate pain and I would be terrible at the rehab. And I look at Jeremy Renner and he's running around on steel rods and I'm just trying to walk and I can't do enough of it. So do you find with a lot of your patients, it would seem to me that if you go through giving birth to children, you know all about pain. So with that in mind as a standard, and when you give birth and you bounce back, and by the time you bounce back, the pain is somehow in your brain abstracted. So do you think that women should be better candidates for hip replacement, knee replacement, because they're more able to handle pain, or no? How do you think that works?
I think women and men are equally good candidates for joint replacement surgery if, right, they have the clinical symptoms that warrant consideration of surgery, because there's no free lunch and every surgery has risk. Okay.
Yeah.
So at some point, unfortunately, you may progress to the point where the shots don't do you any good anymore. And there's some controversy about whether those shots are good to begin with. They help some people they don't. I mean,
they totally helped me. I will say that.
Yeah.
They literally took away the pain, period, within one day.
But there may come a time when those shots are less effective for you.
Okay. Right. Friends tell me that.
Right. One of the negatives with patients having injections, shots in their knee before knee replacement surgery is it slightly increases the risk of an infection after the surgery, which is a devastating complication.
It just happened to an acquaintance of mine, but she had gone through 3 hip replacements. So you've got to wonder what's going on there. But she went to a hospital that is just completely dedicated to special surgery. And then she got sepsis and she could not fight it. And that really scared me. Why?
And
how?
Why? Because again, there is no surgery that a surgeon can do that doesn't put the patient at risk of a complication. And aside from a patient dying, infection is the next most devastating complication for a joint replacement surgery. And I've done thousands of joint replacements in my career. So this should be a shared decision-making process between you and the surgeon, where the surgeon says, okay, Diane, I really think we've run out of options to help you. Your arthritis is bad enough. Your pain is bad enough. Your quality of life and functional compromise is bad enough. I think you should think about this. Then you come into the conversation with, well, I don't really want surgery.
You're right about that.
Right? Of course. I mean, no one in their right mind would want an operation. Let's just agree on that as a premise.
Yeah.
Okay.
Yeah.
Okay. But surgery is still a very effective tool for the right patient. That's the key, the right patient. And then when that patient it's appropriate for them to consider surgery, then the conversation needs to focus on, all right, what are your concerns? Let's talk about if you don't do the surgery, right? Because you, as the patient, are ultimately the one bearing the responsibility of the risk. So, one question that I would ask patients would be, okay, where do you see yourself in 5 years or 10 years? And how Well, no, this is a serious question, right?
And I'm thinking seriously because you're asking me because I'm so concerned for the first time ever. I just quit traveling, but I had an interview with CBS out in Los Angeles, and they wouldn't do it remotely. So I thought, okay, I'm going to try. And I had to use a wheelchair in the airport. It was so disturbing to me. It was such an admission from me to me that I had a real problem. Now I'm almost 80. So it isn't like this is happening at 50. And I would like to work with a physical therapist and get to a point where I'm more comfortably mobile than I am. But I don't know what the future holds. And I have not gone to an orthopedist who took the time. You know, I do want to say that there has got to be a way to have more personalized care or more. I would like more 360 degrees, Dr. Mary, where it involves, like, not one doctor, orthopedist, has said to me, lay off gluten, be very aware of gluten, because, or talk to me about inflammatory foods.
So, Diane, this is one of the reasons why I left the comfort and security of academia, where I'd been my entire career, to co-found VOR Health with a friend of mine, a spine neurosurgeon, who's our CEO, and I'm the chief medical officer. So, a company that's focused on getting people better without surgery when it's possible.
Yes, yes. And I do want to ask you, because you mentioned that you feel that the medical community does too many inappropriate surgeries, spine and orthopedics, and that there are too many surgeries done without the afterthought of how is this patient going to recover. For instance, the acquaintance I had who passed about a week and a half ago from sepsis, from hip replacement, never struck me as a woman who was going to be able to follow through on the rigorous physical therapy that comes after an operation like that. And I hate to be completely shallow about this, but why not? I am. As a fashionista, if I was going to get knee replacement, the scar is so huge.
Oh my God, Diane.
I mean,
I love this. I love this. I love this conversation because, the surgeon is not so concerned about the length of the scar.
Yeah.
And I would tell, there was kind of a craze a few years ago, which has died down, about less invasive joint replacement. And it was like a race to see, like, how could you do the surgery through the smallest scar possible?
Yes. Yeah.
Okay. All right. Here's what's wrong with that. If the implant's not put in properly, not put in well, and the knee well aligned, it will fail. It will fail early. And that is not an adequate trade-off for a shorter scar. So people get patients, and this is, I would say, the fault of the surgeon for not adequately educating the patient to say, yes, I will try and do your surgery through the smallest scar possible. And by the way, we'll pay attention when we're sewing you up to make sure that the scar is going to be as aesthetically pretty. And they're not pretty, but as aesthetically pleasing as possible, right? But a scar is still a scar. And what matters far more is, were the knee implants put in properly? Is the knee aligned as it should be? Are the ligaments well balanced? These are the factors that are going to make the knee replacement work well and not hurt. So like, this is a redirection of getting the patient on board and aligned with what's the surgery trying to do. The goal of the surgery is to significantly decrease your pain. It may not make all your pain go away, and improve your function. And
Yeah.
I would tell all my patients, knee replacement for the right patient is a magnificent a life-changing operation, but it's still not the knee that you had when you were 20. No one can give you that. Divine Mother gave you your knee when you were 20, and none of us poor mortals are, we cannot reproduce that. But for the right patient, it's a great operation. However, I want to go back to your comment about the more 360 care.
Yes.
Because this is a reason why care is less effective in our country, and it's certainly very fragmented, right? Your physician probably rarely, if ever, communicates with your physical therapist about you.
Never. Are you kidding?
Probably never.
Never.
Okay.
No time to do that.
So when Ryan Grant and I started VOR Health, we said, we know there's a better way. Okay. There's a way to give patients a care team that includes a physician who's expert in orthopedics and spine, but not a surgeon, a physical therapist, a health coach. We'll come back to the health coach in a minute. And then a registered dietitian if more advanced nutritional support is needed. And let's give this patient this team so that the doctor can do a diagnosis, work with the physical therapist and collaborate those two together to make sure it's the best therapy program. The health coach to help you with things like, let's improve the quality of your sleep. Let's get you on an anti-inflammatory diet. Let's talk about stressors in your life.
Oh, yeah.
Okay.
When I went through breast cancer, which in a part, I think either exaggerated or was a big road sign with a big red alarm bell to my knee happening. It's interesting. I had all my lymph nodes taken out on the left side. Okay. So this my left arm feels basically like it weighs 500 pounds all the time. There's lymphedema, but less so than there used to be. It's been 5 years. For some reason, when I left the hospital, my right leg had lymphedema and my leg was huge, but there was somebody famous in the room next to me and he was passing away and there were millions of people in the hallway and the doctor said, leave before this man passes on because you're not going to believe the chaos. And you're better off at home. So I left the hospital with one leg twice the size of the other. I was bad about exercising it. And that seemed to start the journey towards recognizing the pain. But I did say to this orthopedist that I go to, which is basically is put on a pair of paper shorts, wait for her to walk in the room. She says, are you ready? I say, yeah, I've been ready for 6 months. And she gives me a shot of gel. And I say, so doctor, I got a red light device. And people said, oh, red light is really going to help your joints. And what do you think about that? Crickets. Well, what do you think about a gluten-free anti-inflammatory diet? There is I feel like it's like politics. It's like medical politics, like in politics. Whatever party it is, gets a little memo they print out and it says, talk about this. Don't talk about that. I don't know what's happening. There's fireworks. See what I mean about me? You just never know. Okay. So
the reason why that happens, Diane,
it's all because of insurance and getting sued, right?
It's not
about the good of me or any
it's
other.
not just that. It's that the doctor has a limited amount of time with you. And actually, the orthopedic surgeon that you saw And fantastic that you see a woman, because, I've spent my entire professional career promoting diversity in orthopedics.
Yep.
Um,
Yep.
is that even that surgeon, as well educated as she is really not educated on talking to you about an anti-inflammatory diet. Okay. Now, conceptually, I'm sure she knows that's a good thing. But what you really need is you need somebody who can work with you, like a health coach, or for people that need more advanced nutritional support, we pull in a registered dietitian who can help you start to make the small changes in your diet that will lead you to success in an anti-inflammatory diet world. Okay.
It's funny. My housekeeper, who I've had for 15 years, and of course we're growing older together, and she's got problems with the bottom of her feet and her elbow and this and that. So she's in my refrigerator today, and she goes, "Ew, you've got non-gluten bagels." And I said, "Yeah, shoot me. What is the problem here?" And she said, "Oh, I hate non-gluten bagels and breads. Oh, it takes all the fun out of eating." And I said, "Yeah, but Carolina, stepping on a knee that feels bone on bone is like the least fun thing I can think of to do. Putting yourself into a situation where you are getting pain out of unnecessary amount of movement, and your pain comes from weight bearing. I never, honestly, Dr. Mary, I never in a million years thought that would be me, ever. And then, I guess I must think of myself as a 50-year-old, but I'm almost an 80-year-old. And so there's going to be a certain amount of aches and pains that come along with it. But what I would love is if I said all of that to my doctor, and she said, "Diane, this is Mount Sinai Hospital. We are huge and all powerful. Of course, we've got a dietitian that's going to talk to you. And of course, we've got alternative medicine that's going to speak to you about red light theories. And of course, we've got PTs and on and on and on." But they don't. And I get a feeling that there have been way too many class action lawsuits that prevent them, and they've got their own little list and Bible of what they can talk about, and those are not it.
Well, I'd say my response to your comments would be two primary ones. One, a lot of what happens is what insurance will pay for. And Medicare.
Yes,
and if you have Medicare, which most older people do.
I do.
Right? Okay. Medicare does not pay for a lot of nutritional services unless you're diabetic and you actually already have kidney damage from your diabetes, which is.
But they won't even, like, if you have a vacation and you want to get the shot a week early before your vacation. Oh, absolutely not. Yeah. You have to do it only on the prescribed day. That is 6 months and 1 day after the last shot. And so I guess I want to end this podcast by asking you, I'm an old girl, and I remember as a kid having the measles and the mumps, and God, the doctor came to your house and he sat with you and he talked to the parents and he comforted me. And it is so far away from that now. Medicine is so walled up because of all the insurance and all the conditions of government care through Medicaid and Medicare that I feel you really have to have the time and the money and the self-motivation to take care of yourself in a real integrated manner. And so I miss those old days, I have to tell you.
Well, I understand, but a couple comments. One particularly for women, and I'll plug my book, Taking Care of You, The Empowered Woman's Better Health, because women's health is not just the bikini areas. It's not just breast and reproductive medicine, right?
Yeah.
And a lot of conditions impact women differently than men because we are biologically different. Our tissues are different. Every cell in our body has a sex. A person has a gender, but every cell has a sex. And so our book, my co-author, a medical anthropologist, Conwell Hawk, we have 55 common clinical conditions. It's all structured and very easy to read, written for the average person, right? Not a medical professional. So what's the disease? Why does it start? How is it treated? Are there differences between men and women? Are there differences between white women, African American women, Latinas?
I'll bet there are.
If the data was there, that's included. Questions that you can ask your healthcare team and pearls of wisdom from the experts. So boom, right there. So the woman can be empowered when she goes into that clinical encounter to be more knowledgeable and feel more confident about asking questions. So that's one way because we have to approach the issue from two perspectives. One, making the healthcare more patient-centered, okay, which is what telemedicine does.
Absolutely.
And number two, helping patients be better advocates for themselves and their own health.
Yeah, and I do want to say that obviously when I went through a double mastectomy, I was given a lot of drugs that I really protested and said, I am not taking Oxycontin. Like there were all that stuff about the Sackler family and TV, and I knew the Sackler family, and those drugs sit in one of my drawers as a reminder that I went through it literally with Tylenol. And every once in a while, it gets to be very tempting when you're having a really bad day with your knee or your hip, and you are maybe invited out to a social event. And I use a cane right now, which I hate, but have to. And, I think that one of the things we don't talk about is pain alleviation, alleviating pain without becoming a drug addict.
Yeah.
And they were giving out Oxycontin to me like it was candy. Seriously. And I never took one ever. And
yeah, there have been a lot of advances in that regard. So,
there have?
Yeah, there have. So, opioids now are used much less for after surgeries, even like knee replacement surgery. There's nerve blocks. There's all kinds of other ways of helping to control the pain after surgery.
And see, no one ever told me anything. I'm hearing this from you, Dr. Mary, on a podcast when my own orthopedic surgeon never even mentions it. And to me, it's you come in as a layman, you coming in wanting your doctor to like you, so they're nice to you, or they give you, God forbid, an extra 2 minutes, but you never walk out fully prepared. You never walk out with a rounded picture. And I think what you're doing is so invaluable. Wow.
Well, thank you.
I applaud you. I really do. And I think it probably is a lot of my audience saying to themselves, well, that pain needs to get taken care of, but how do I do it? Because I also feel I live in a huge city, Manhattan, New York City, some of the best medical care in the entire world. And yet I come away from those appointments. I'm going to have one next week, and I guarantee you it's not even going to be 12 minutes. It'll probably be about 5 minutes. And they'll spray my knee with lidocaine, and they keep spraying my knee with lidocaine and spraying it and spraying it. And she puts in the needle, and I always say the same thing because I'm looking away. So when are you going to give me the shot? And she always says, Diane, I already gave it to you. And I say, oh. She says, well, gotta run, got a million patients, bye. And that is the summation of going to one of the best hospitals in the world to get orthopedic care. It just,
Diane,
I wish there were more of you. I wish there was more three-dimensional thinking and more personalized care, because I think that really the hallmark of growing old, I can tell you right now, without equivocation, there are huge parts of me, even with a tremendous amount of chemotherapy and radiation, that haven't aged. I have very, very, very few aches and pains or complaints, but my knee is killing me. And if you don't want surgery and you want to try and handle it holistically, at least in this country, good luck. If Medicare and insurance doesn't recognize your need for out of the box solutions, you're not going to get it.
I know that it's challenging. Again, that's why, we founded VOR Health, because we really believe that there's a better way to approach patients with that, more holistic care, because
Oh, yeah.
you're not, because you're not just a knee, Diane,
Yeah,
you're not just your
I'm an
knee.
entire body with
Exactly.
a skeleton and a hip that's involved. And yeah, and that was the other thing that just drove me nuts. The last time I saw her, and I went too early, so I just got a cortisone shot. Then I have to come wait 6 weeks, 7 weeks, and come back for the gel shot. She said to me, you're a candidate for knee surgery. And I thought, but it's not really my knee, it's my hip. So now what do? Now are you a candidate for hip surgery? Or yeah. So guess what? It's the ins and outs, it's the ups and downs of aging. But what choice? You gotta work through it.
Privilege. It's still a privilege for us to be able to age.
Such a privilege. Imagine. I mean, I went through a mortality-based disease with not a good prognosis. And I came out shiny and new on the other side, and realizing how precious life is. But realizing how precious life is, I'd like to do something for my knee that was better than what I'm doing and not have to go through surgery. So guess what? I loved this. And you are a practitioner that I think the whole idea of virtual medical care is brilliant. And we will put all the graphics into this podcast so people can connect with you. And marching forward with medicine in the 21st century is everything.
That's my passion, Diane. I loved when I was individually taking care of patients and operating on them. I found it was such a privilege. I mean, honestly, if you think about it, that you trust someone enough that you let them cut you open.
Yes.
Okay.
Exactly.
No, I mean, really, what?
Oh, really, I'm with you.
What a position of privilege for me to be in. But now, I want to help. And as much as I love taking care of patients and supporting their families, I want to have a bigger impact, an impact on a bigger scale.
Yeah.
Because I know we can do better. And so now I'm having a lot of fun with VOR Health and with the book, and that's what drives me.
I want to say, in conclusion, especially to females who are listening, we tend to settle for second best care. We tend to be too meek and don't want to bother the doctor, especially if I have a couple of doctors that are pretty grumpy. We don't want to bother them. So we sort of walk out without the information we need, but we're going to kind of piece it all together and make do. I don't think we should be doing that anymore, ladies. And especially as you age, I mean, my life is limited because of only one thing, arthritis in my right knee, and not wanting, after going through a double mastectomy, anybody could understand I'm not dying to go through surgery again. But it is the mission of this podcast to present to everybody choices and alternatives that can give you a better life and maybe a bit out of pocket. And Dr. Mary O'Connor is not only in pocket, but she's out of pocket too. And that makes her the perfect guest for too old to be young. No, actually too young to be old. Yeah. So with that, guess where I'm going, everybody? I'm rushing to my physical therapist for my knee. This is it. Oh, yeah. Total connectivity. Dr. Mary, thank you so much for joining us today.
And it was my pleasure. And I just hope the audience enjoys this as much as I have enjoyed my time with you today.
Always. It always works that way. Thank you so much. Thank you so much for listening to Too Young to Be Old podcast. The episode may be over, but the fun doesn't have to stop here. Find us on Facebook, Instagram, TikTok, and YouTube at The Diane Gilman, or visit our website, thedianegilman.com. If you like the show, leave us a rating or a review and subscribe so you don't miss the next episode. And until then, don't forget, age is just a number. Together, we'll prove that we are all too young to be old.